My name is Koloud Alkhamaiseh. I am an assistant professor at Michigan Technological University, Michigan, USA. I am happy to be a speaker today at the Global Insight Conference on Artificial Intelligence 2024. My research focuses on using machine learning and deep learning modules to analyze medical images, and I will talk about some of our previous research and current research in this presentation. We will talk about how AI and machine learning modules can enhance laparoscopic and robot-assisted surgery safety. As we know, AI is transforming the world and also transforming the laparoscopic and robotic surgery by enhancing precision, efficiency, and patient safety. We will talk about some of the latest AI techniques in laparoscopic and robotic surgery. Also, we will talk about deep learning for surgical precision and advancement and implications. When we talk about advanced technique in AI integration, we focus on image segmentation and anatomy mapping, as this very important field in laparoscopic and robotic surgery. The most famous and the de facto standard, we can say, for medical image segmentation is UNIT. And its variances and these variances are built based on units and make it more powerful by extracting more features. And this is what we need. We need to build our model based on more features to make better prediction. As you see here in this image, this is the general architecture of the basic unit that have the encoding parts and the decoding parts. These layers try to extract features from medical image, then train the model based on these extracted features and using this trained model to make prediction on a new tested image. And this can be applied on laparoscopic videos, images at real time. It depends. So we can say the advanced architectures like units are used to segment complex anatomical structure from laparoscopic images that can provide real-time guidance and reducing the risk. The other model that also offer detailed segmentation map, and it's very useful for real-time application, as you see here, is DeepLab. As you see, this is the general architecture of DeepLab. There is a lot of details. I do not want to go through these details. We can also think about augmented reality and how this can enhance visualization. AI-powered augmented reality systems overlay critical information into the surgeon's fields of view, and this is very helpful and can improve spatial awareness and decision making. I know maybe virtual reality sometimes it's not practical, not real, but AI will make it maybe more more practical and more helpful in the operating rooms. How AI can increase the operational efficiency and patient safety? This can be reached through predictive analytics and decision support. When we talk about predictive models, AI predicts potential complications and outcome. This will allow for proactive measures and enhancing patient safety. While in decision support systems, this will provide real-time recommendations and alerts, aiding surgeons in making informed decisions during surgery. Also, it's also will be very helpful in 3D reconstruction. The AI model can create 3D models of the patient anatomy from the 2D images that we have, and this will improving the surgeon's understanding of the operative field. Also, AI-powered robots in robotic assistant and automation as a part of this field. Systems like Divinci surgical systems use AI to enhance precision and control during tasks like suturing and dissection. Also, autonomous surgical tasks. AI perform specific tasks autonomously under human supervision, improving the efficiency. We cannot forget natural language processing and voice assistant, as this will be part of voice control systems that can help surgeons control equipment and retrieve information without diverting attention from the surgical field. So they are still focusing only hearing from the control system, voice control system. Also, natural language processing for documentation. This will automate the generation of surgical reports, ensuring accuracy and will save much time. When we think about also machine learning models that can use for analyzing surgical videos to assist skill levels for surgeon training, this will providing feedback and training based on metric like, for example, tube movement, precision. Also, gesture recognition can recognize and evaluate specific surgical gestures to standardize techniques. On my previous lab at Western Michigan University, we worked on FLS Box Trainer. We built many modules to assist surgeons during the training based on fuzzy language, based on computer vision, and many research focus on machine learning. Here I have some pictures from my previous research. Here I am using color filtering in computer vision to track the scissor tips and tell the surgeon where he was cutting through the training and give him a detailed report at every instance, at every part of the second, third part of the second, where he was, and give him an assessment based on fuzzy logic. Also, I used YOLO version 7 to track the surgeon tips and tell him using object detection with bounding boxes, the position, the exact position now, and give him near to real time tracking through the training. And my colleagues at the lab built other models, and we built at the end of this time, we built an overview, a summative assessment for all tasks. We focus on pattern cut, as in my research. Also, my colleagues focus on peg transfer and also in suturing and needle movement. I want to talk a little bit about my research and how I used UNIT with updating UNIT with other important deep learning model. We call it autoencoder. I incorporate autoencoder in UNIT to get better results in segmenting gallbladder important or CVS critical view of safety in gallbladder surgery landmarks, important landmarks. My research was titled Toward Reliable Hypocystic Anatomy Segmentation in Laparoscopic Cystectomy using UNIT with autoencoder. This is the general procedure of our work. We start with data collection. We have a data containing 200 videos of laparoscopic cystectomy surgery from computational analysis and modeling of medical activities research group, free videos from the World Laparoscopic Hospital videos, and free YouTube videos from the Society of American Gastroenterological and Endoscopic Surgeons. We collected, extracted, and labeled around 1,550 images. They are free for anyone want to use it in their research. I am happy and glad to help. And I already uploaded in one of the free websites as a data set that anyone can use it. data labeling and data extraction, it's not easy step. It took us around 3 to 6 months. I will talk about this in the next slide, how we collect the data and build this data set. These images were extracted and selected to give a clear view of the intended landmarks, even with some special cases, but we try to reach a good standard that the model can learn exactly what each part will look like at pixel level. So after that, when we collect this data, we trained our autoencoder part. We extracted the weight. So our unit model will not start from scratch, start learning. No, there is a pre-trained weight that can help the unit train and learn faster and get better features and a better understanding of these landmarks. Then we train the model based on this pre-trained model that we just built it from autoencoder at this part. Then we test and make a prediction on a new image that the model didn't see before. And then we evaluate our performance. So as you see, we have here 2 stages: data pre-processing and building autoencoder, and we have here CVS segmentation, prediction, and evaluation. Here is the process, an example of this is the original image from the video, and this is the manual annotated frames. We use Fiji plugin annotator that is used effectively to annotate the extracted image with CVS criteria. And expert surgeons from Stryker, led by Dr. Chaprine, with his team, helped us to confirm the data and it's labeled correctly for each single image extracted in this data set. And this is the output segmentation mask. We will use this data to train our model. First, we use autoencoder, as I told you, and then we trained our model based on this pre-trained modules. UNet is deployed as the segmentation network in the proposed model that we built, in which we transfer the gained autoencoder weights and use it as the unit encoder weights. As you see, we extract here the weights and use this weight in our unit autoencoder, encoder part. The weight were transferred to the first 40 layer of the unit encoder, and this is helping the unit to extract and learn from these features. We used many evaluation functions to evaluate our trained model that we built using autoencoder and UNet. A hybrid loss function was used where it's combined 3 loss functions: dice coefficient, cross entropy, and focal loss, in addition to Adam optimizer. These are the graphs of our model training and validation process. The training is for the red and the validation for the blue line, as you see here. 5 experiments with different weights, model, and technique were made to evaluate the model that we built. The training process ran with a patch size of 16 for 100 epochs. Adam optimizer was used and initialized with a learning rate of 0.01. And we can work on that. As you see, this is a quantitative results that we got. The first experiment is using UNet with autoencoder weights and without data augmentation, without adding more data, with only flipping, blurry view, some distraction that can give us more data. We get a good accuracy with 92 and with a good mean IOU with 74.6, 5414. To my knowledge, this was the best result in gallbladder segmentation. I don't know if other people get better numbers, but to this research, to my knowledge, this was the best results. Also, we have without data augmentation, also with data augmentation, it was not good as without augmentation. And that, as you know, as we have more pre-trained weight, we will get better results. So also we test our model using ReasNet backbone, and we reach an accuracy of 95 and mean IOU with 80.8%. And the precision reaches 97 in this experiment. Here, a qualitative comparison for all experiments. So the same picture, and you see here, for example, this part in the labeling, manual labeling is not labeled, but the system can predict that this one is part of the liver. And it's give us a wonderful results. As we know, abdominal organs differ between patients. Subhanallah, each one is a unique. And it's not an easy task to identify the intended landmark during their surgery, where these structures have different shapes, sizes, and colors, and sometimes lie hidden within other tissues, such as fat or another structure. So surgical videos are filled with visual disturbances that makes anatomical structure identification very difficult. Let's look at these examples. Here we have new cases. As you see, here we have all the parts segmented precisely. We have the gallbladder, the liver, the cystic duct and cystic artery, and even the tool, it's cut it here, as you see, as background image. Also, this is another image with new shapes for the system. Also here, extraction, we got accurate extraction of surgical tools. As you see, this is the yellow area with as segmented as background. Also here we have segmenting special landmark structures. This is very unique case in the world. We have 2 gallbladders, we have 2 cystic ducts, 2 cystic arteries. Although our system didn't see this before, because this is very unique case, the trained system, the trained model can predict each part efficiently. And this was wonderful. Also, segmenting special landmarks where we have, for example, 2 cystic ducts, 1 cystic artery. The system can identify that we have here a unique case with more than the standard that we have only 1 cystic duct, 1 cystic artery, as you see here. So we have duplication here. Also, we have segmenting others, as you see here, other special cases. Here we have a video that the surgeon look at it. It's not at real time. We try to reach a real time, but can help the surgeon see in different views how the surgery happened and can give a good feedback. You see how even with the flipping, the system can still predict, and we can manage the speed, we can manage the colors, so the surgeon can see what he wants exactly, what he can benefit from this video.
Good afternoon. This presentation is...
Hello. Look at it. It's not at real time. We try to reach a real time, but can help the surgeon see in different views how and navigation aids. So will reduce the margin of errors. Also, AI will improve the training. Automated skill assessment and feedback systems help in the training of surgeons, ensuring high standards. Operational efficiency. AI-powered tools and predictive analytics streamline surgical procedure, reducing time and improving outcomes. Patient safety. What we want. Real-time decision support and predictive analytic help in preventing complication and improving patients. We need to explore the potential for future advancements in AI integration, enhancing precision, efficiency, and patient safety in surgical procedures. Also, we need to discuss the collaborative efforts and interdisciplinary approach driving the evolution of AI in surgical practice. In conclusion, these advancements in AI are transforming laparoscopic and robotic surgery, leading to better outcomes, enhanced safety, and more efficient surgical procedures. The integration of deep learning techniques is very helpful, and we need to embracing the advancement in AI for surgical procedure for improving patient outcome and advancing the field of surgery. Thank you for your listening, and I'm ready for any question. Thank you and have a good day.
Dr. Koloud, Alkhamaiseh, are you there?
Yeah, I am here. Is there any question? I'm ready to answer.
Yeah, please log in so that
I am, yeah,
yes, we can see you.
yeah,
Yeah, if there are any questions, please interact with her.
yeah. I am sick today also, so it's better that I recorded and you uploaded the recording.